The North American Spine Society Guidelines for Conservative Management of an Acute Lumbar Disc Herniation outline a standard pharmacological progression. For most patients, the prescribed first line of defense includes nonsteroidal anti-inflammatory drugs and glucocorticoid steroids. This protocol is deployed to address a highly specific clinical presentation, a patient suffering from acute radiculopathy, where a compressed spinal nerve root causes severe radiating leg pain. The anatomical goal of this conservative treatment period is spontaneous disc resorption. If the extruded disc material physically shrinks and recedes from the nerve root on its own, the patient avoids decompression surgery. But physical resorption is not a passive event. It relies entirely on a highly active pro-inflammatory cellular cascade. When disc material extrudes, the body recruits macrophages to the site. These immune cells physically degrade the matrix of the extruded nucleus pulposus and stimulate new blood vessel formation. NSAIDs and systemic steroids operate by chemically blunting this exact inflammatory cascade. Their primary mechanism of action halts the recruitment of the cells required to clear the debris. Standard first-line therapies efficiently mask radicular pain. However, by suppressing the local immune response, they can stall the body's innate anatomical healing mechanism. A 2024 prospective study published in the European Spine Journal by Albert et al. Tested the clinical outcomes of a radically different approach, a strict inflammation-preserving protocol. The central rule of the trial was absolute. Patients were strictly prohibited from taking any NSAIDs, oral glucocorticoids, or corticosteroid injections. This diagram outlines the primary clinical outcomes for the 90 symptomatic patients enrolled in the trial. The data shows a 100% rate of MRI-verified disc resorption, alongside a 0% rate of surgical intervention. Every single patient in the cohort achieved significant physical resorption of their herniated disc within 12 months. An absolute success rate in anatomical recovery raises a direct physiological question. Routine anti-inflammatory prescriptions may actually be prolonging the duration of disc herniations by artificially arresting the body's repair sequence. An acute lumbar disc herniation begins as a mechanical failure. The pressurized inner core breaks its barrier, breaching the annulus fibrosus and protruding outward. This uncontained tissue stress immediately sets off a chemical alarm. The local cells release pro-inflammatory cytokines directly into the epidural space. This flowchart maps the cascade. Cytokines act as a homing signal, recruiting leukocytes and plasma proteins to the injury site. Once macrophages arrive, they consume the herniated tissue matrix and drive capillarization to transport waste. The body switches to lipoxins, initiating an anti-inflammatory repair phase. Introducing synthetic NSAIDs or glucocorticoids early in this timeline intercepts the process at the recruitment phase. It freezes the necessary macrophage activity before matrix degradation can finish. By treating the sensation of pain with anti-inflammatories, the standard of care actively sacrifices the cellular mechanism of structural repair. The Albert trial evaluated 90 patients, all presenting with acute disc herniation symptoms lasting fewer than 3 weeks. The researchers faced an immediate clinical hurdle. They had to ethically manage the severe radiating leg pain caused by nerve compression without utilizing any standard anti-inflammatory regimens. Their pharmacological substitute was gabapentin. By utilizing titrated doses, the researchers targeted the neuropathic nerve pain directly, bypassing tissue-level inflammation entirely. To support the pain management, this protocol also included 12 consecutive weekly sessions of acupuncture as an adjunct therapy. This diagram shows the exact methodology. The schedule relied on sequential MRI check-ins, separated by 3-month intervals, alongside a mandate enforcing the avoidance of NSAIDs. To exit, patients needed greater than 40% physical reduction in herniated tissue and 70% improvement in pain. By isolating neuropathic symptom management from the site of tissue damage, the protocol allowed the body's natural inflammatory healing timeline to proceed unhindered. Proving that anatomical recovery was taking place required multi-imaging evidence spanning a full 12-month period. Here is direct visual proof of the tissue regressing. In panels A and B, the mass retracts from the epidural space for the fast and medium groups. Panels C and D capture the slow and prolonged cohorts, requiring longer multi-frame progressions to hit clearance. This graph quantifies that physical reduction, tracking the volumetric shrinkage of the herniations in square millimeters across the 3, 6, and 9-month intervals for all groups. Across the entire cohort of 90 patients, the mean time to achieve complete required resorption was exactly 4.4 months. The exact timeline for macrophage degradation fluctuated based on individual physiology, but the anatomical end state of physical resorption was universally achieved. The baseline size of the herniations averaged 119.5 square millimeters. Interestingly, the initial size of the extrusion correlated only weakly with the baseline severity of the patient's leg pain. The biomechanics explain this relationship. Smaller physical extrusions induce less mechanical pressure against traversing and exiting nerve roots, generating slightly lower pain scores. However, the initial volume of the herniation did directly dictate the starting dose of gabapentin required to reduce the patient's pain to a tolerable level. As the physical mass of the herniation shrunk over time, the required chemical intervention vanished. By the third treatment interval, average gabapentin utilization plummeted to near zero. A larger initial herniation simply requires a longer duration of macrophage-driven capillarization to completely resorb. The volume of the injury stretches the timeline, but it does not alter the 100% success rate of the biological mechanism. These three Kaplan-Meier plots illustrate the precise rate at which the cohort achieved structural clearance, mapping the survival curves for the time to reach 25, 50, and 75% disc resorption. The timeline of this physical tissue resorption directly correlates with clinical relief. This plot tracks the survival probabilities for time to pain resolution, mirroring the timeline of the degrading disc mass. We can measure the efficiency of this protocol against historical data. A major meta-analysis examining 587 conservatively treated disc herniation patients established a comparative baseline where the standard protocols typically included NSAIDs and steroids. This side-by-side comparison shows the historical meta-analysis yielded a 66.7% resorption rate. The inflammation-preserving cohort achieved 100%. Protecting the inflammatory cascade rather than suppressing it yielded a 33% improvement in complete anatomical repair, allowing every single patient in the cohort to avoid surgical intervention. The Albert study is a prospective cohort. It lacks an internal, randomized control arm for direct, isolated comparison within the exact same testing environment. Yet the clinical outcomes perfectly mirror the established cellular biology. The 100% recovery rate aligns precisely with the known pathophysiology of macrophage-driven matrix degradation. Managing radiculopathy with a neuropathic agent like gabapentin, rather than a systemic anti-inflammatory, correctly separates the requirement for pain management from the biological necessity of healing. Validating this approach at scale will require large, randomized, controlled trials. Those trials are necessary to formally challenge and update the existing clinical guidelines. Ultimately, effective conservative management facilitates the body's innate inflammatory repair, rather than chemically silencing the natural healing response.